And the problem with pulmonary hypertension is it comes in lots of flavors, including heart disease and lung disease, and we'll go through a classification system for all of you this morning. But I think the way we're going to get started at a primary care focus is really talking about dyspnea evaluation, because at its heart, pulmonary arterial hypertension, one of our center's major diseases, is a really rare disease. But boy, dyspnea out there in all of its forms, very, very common. A lot of that from subtle congestive heart failure. Everybody gets short of breath with their lung disease or congestive heart failure. And how to work through all of that is really a big deal. I have a single disclosure. Actelion, one of the sponsors for this conference, actually makes a bunch of pulmonary arterial hypertension drugs, but we'll not be talking about their drugs specifically. So it just looks like every one of the diseases I'm talking about, mortality is increasing these days, and so pulmonary hypertension is no exception to that. This is data over the last 10 years that says despite now having 9 FDA-approved medications for pulmonary arterial hypertension, we have a large unmet need both in diagnosis and treatment, and a lot more drugs on the way in this pulmonary hypertension space. Everybody, number one, none of your patients know what the word dyspnea means, right? So when we start saying this word, you got to be careful. But we got to realize that this is a neurologic sensation that you can't see, you can't define. And so when someone comes in to tell you that they're short of breath, I hear the story all the time. Yeah, I went to see my primary care guy, and he said there's nothing wrong. And the point is that shortness of breath is a neurologic symptom that you really can't tell them, just like pain, whether it's there or not. Nothing you can observe in this patient. And the words our patients use are difficulty breathing, tightness in the chest, air hunger, shortness of breath. But the list is very, very long. And so I think what we want to do today is kind of go through and just make sure everybody has the checklist so that when you're sitting there in your 15 or 20 minute slot in the clinic, you can make sure that we've at least hit most of these bullets as we go. Number one on the list, heart disease. We'll break that down again in just a minute. Number 2, lung disease. Don't forget anemia here. This is an indication for CBC. Remember that I'm short of breath, and now you go to your cardiologist and your pulmonologist. They'll come back to you if you've not checked to see if their hemoglobin is 7. The last 3, neuromuscular disease, is usually a physical exam finding. Most people will complain that they can't arm wrestle their grandkids as well enough or get up from a chair, but it's an easy enough exam to have them rise from a chair without using their hands in the office to really check those thigh muscles and see how strong they are. Pulmonary vascular disease, the topic of our larger topic. And then this whole concept of who has shortness of breath from brain issues is really a very, very difficult topic. And remember that our respiratory drive centers are in our brain stem, and so you'll usually see other neurologic conditions there. The workup for this means that you got to go bullet by bullet. So this is the EKG and stress test and the echo and the Holter for someone that you think has cardiovascular disease. On the lung side, beginning with spirometry and a chest x-ray is reasonable, a CBC, and then your neuromuscular disease in addition to your physical exam is EMG nerve conductions if you start having issues that you think might be a myositis or a peripheral neuropathy. Pulmonary vascular disease, we're going to talk a little bit about exercise tests that you can do in your office as a way to help sort all of these out. So let's go into each of these individually. So heart disease, you don't have a cardiologist here this year. Dr. Basil invites a cardiologist about every other year up here, but he does a lot of that cardiovascular stuff himself. Coronary artery disease, we mentioned yesterday, number 1 killer in the United States. Everybody's pretty good at making that diagnosis with stress tests that are about 95% specific for these sets of diseases. Usually has the risk factors that everybody's very well aware of. Heart failure, though, is a little bit different. Everybody that goes for the echo has cardiologists that are very, very good these days at picking up an ejection fraction. And so they recognize systolic heart failure very, very well. But I'll tell you from running a pulmonary hypertension center that about 3/4 of the patients that are referred to us have had an echo that shows no or diastolic dysfunction appropriate for age until we go in with the right heart cath and prove that your left ventricular end diastolic pressure or wedge pressure is 32 or 34 and have pulmonary venous hypertension. And so we'll talk through the issues here with diastolic heart failure recognition on an echo. Obviously, echo machines, like all technology, are getting better and better and better through the years. But you also, this is a physician-dependent test on how well they look for and measure the other determinants of diastolic heart failure. These would be things like left ventricular wall thickness. After you've lived for 30 years with hypertension, if you have a big, thick LV wall outside the limits of normal, you have to have accelerated attention to that. And think about it, there's no other way on an echo that you should get left atrial dilation unless you have problems with that stiff ventricle sending blood back up the pulmonary venous circulation into the left atrium and then further up into the pulmonary veins. So in heart failure, we're really talking about pulmonary venous hypertension. And there are other causes of pulmonary venous hypertension. I guess the most common of yesteryear would have been mitral valve stenosis from rheumatic heart disease, which we don't see as much anymore. But thinking about pulmonary venous hypertension in that large left atrium, by far and away the largest source of diagnostic challenges in pulmonary hypertension is failing to recognize diastolic heart failure in that large left atrium as the cause of atrial fibrillation and dyspnea. Lastly, in heart disease, arrhythmias. Arrhythmias are rarely the cause of dyspnea, unless it's episodic, and most patients can kind of tell you, yes, at 10:03, my heart started racing, I got very short of breath and or syncopal, and then whatever happened. And obviously you have to know what the rhythm is. The most common rhythm associated with dyspnea is paroxysmal atrial fibrillation, but you can't just go into therapy without capturing that. And so now we have our 24-hour Holter monitors and our 30-day event monitors that are fairly prolific out in the community that are used often. So this is dyspnea from a pulmonologist perspective for heart disease, but I just wanted to really highlight the diastolic heart failure here. From lung diseases, we talked yesterday about the obstructive lung diseases, and the point is that spirometry is very, very good for this one. We'll have an occasional patient with advanced emphysema that has completely normal spirometry, and the point is that spirometry is not 100% sensitive for all forms of COPD, even though we presented as pretty standardized yesterday's, but we have, that's one of those unique phenotypes of COPD. On the restrictive side, remember that this was the pattern where you have a decreased total lung capacity, and so that what happens when you breathe in, you don't breathe in the full complement of volume. Therefore, when you blast it out, what happens is your forced vital capacity stays short. Now, after I didn't leave you time for questions yesterday, I got a few about our spirometry, so I thought I'd take this morning and spend a little bit more time on our spirogram. This is a forced maneuver in your office in which individuals take the biggest breath they can and they blow it out for, by our American Thoracic Society criteria, a minimum of 6 seconds. So let's everybody do it this morning. 6-second expiratory time, big breath in, blast it out as hard as you can. 2, 3, 4, 5, 6, full inspiration, and you finish your flow volume lift, right? Yeah, here we go. Everybody that's coughing has asthma, and it's a hard test to do, right? And grandma has to do 3 of them that have an FVC, the total amount of volume that comes out, that's within 5% of each other to have adequate accuracy of testing. And so the average number of tests you need to do to get 3 within 5% are 7 tests in the laboratory. You take the 3 with the highest FVC within 5%, and the highest one is the FVC that's recorded. Why all this stuff? Well, it's real important when I'm trying to figure out whether somebody has progression of disease, whether my therapy is working or not, to have accurate tests. And when we do it accurately with the parameters I just laid out, we have about a 7% test-to-test variability in that test alone. So we're having to watch not only the tests you do today to help your diagnostic planning, but also once you have a disease state and are trying to measure, you recognize there's a little bit of variability. But with all that said in our restrictive lung diseases, what tests do we use to monitor myasthenia gravis when we come into the hospital? It's your FVC. You're watching to see who needs support in the ICU versus not, and who needs assisted ventilation. When we go to the neurology clinics, almost all their diseases that affect the lungs, we're measuring FVC. It's a number. It's not how you feel today. And so it's a very accurate measure. All of our FDA trials and all of our scarring lung diseases, FVC, it's our most accurate measurement of how you're doing in our restrictive lung diseases. Now let's talk a second about FEV1. So if my FVC is supposed to be 4 liters, but my scar in my lung or my neuromuscular disease is making my FVC be half of what it was, will my FEV1 be normal? No, my FEV1 can never be higher than my FVC. So as my FVC begins to decline, my FEV1 by necessity has to decline. And so it's the ratio between FEV1 and FVC that defines obstructive lung disease when less than 70% or 0.7 when you're using the liter specific numbers. And so the ratio will be normal in restrictive lung diseases, but now we'll look at your percent predicted FVC as the measure by which we're going to grade the disease process. So this can be diseases of the lung parenchyma, it can be diseases of the chest wall, scoliosis, neuromuscular disease that makes our FVC fall. Restrictive spirometry, puffers aren't going to help. It's a disease of our gas exchange at the volume level, restrictive spirometry. Okay, and that brings us to the list, and the list is long. And when we start talking about dyspnea, we're going to be talking about normal spirometry for the most part. And so to recognize restrictive spirometry, know you need to go a different direction is real important. So these are our interstitial lung diseases, which are our topic for the next hour later on. Our alveolar filling diseases, such as pulmonary edema or pneumonias, lung cancers, large heart, mediastinal masses, things that take up space inside the chest, and diseases of the chest wall and pleura, pleural effusions, scoliosis. Most commonly, obesity has an overlay here, but it takes more than 20% of your ideal body weight to impact spirometry at all. So restrictive spirometry, limitation of vital capacity, and that 6-second expiratory time, really important to get maximum volume that's reproducible in our quality control of spirometry in the laboratory. Okay, there are some of these that the patient comes and says, yeah, doc, you know, I've been getting more and more short of breath, and it's been going for 3 months. And so you say, yeah, let's do a spirometry and get a chest x-ray, and they both come back normal. So what are we thinking about here? Well, the list is pretty short there. Some of these obstructive lung diseases, I mentioned emphysema, can be disproportionate, so we will sometimes advance to a CT scan. Coronary artery disease, heart failure, clear chest x-ray. If you are not advanced, heart failure that's advanced will give you pleural effusions. There are some of the pulmonary fibrosis presentations that will actually have such mild disease that you won't see it on chest x-ray, but the CT scan is much more sensitive. And then our pulmonary hypertensive diseases. So you advance to this chest CT, you see a clear lungs here, you send them for a stress test that comes back shortened exercise time, but no coronary artery disease, and you now are left with a disease that is increasingly limited to this group of diseases that are often missed with long diagnostic delays of pulmonary arterial hypertension that we're going to talk about as the rest of the talk. So part of the message here, don't forget about pulmonary hypertension in the talk. So let's move on into, I know you can't read this, it was out in the handout though, but these are our interstitial lung diseases that we're going to talk about in the next hour. But these are the ones in which we don't know, in which we do know the etiology. So lots of inorganic dust here, so asbestos, beryllium, aluminum dust, any of you that work in an industrial exposure community are important. We've got all of our drugs over here. We've got about 60 now organic dusts that we inhale and have a disease called hypersensitivity pneumonitis. This is the farmer's lung or the patient with a parrot or the parakeet inside their house that inhale bird dusts and to which they're allergic. We've got things like radiation pneumonitis, lymphangitic carcinomatosis on this list, but the list is very, very long of all the different things that cause scar in the lung. We have a similar list of all the diseases that we don't know a cause that cause interstitial lung disease. On top of this are our idiopathic interstitial pneumonias that we'll address next. We have a bunch of pulmonary hemorrhage disorders like Goodpasture's disease and all of our vasculitides that affect the lung on this list. Amyloidosis, sarcoidosis, we still don't know the cause of, but the list again is really quite long. The key here is really the high-res CT that helps you with sorting out the interstitial lung disease. Very sensitive test, accuracy over the chest x-ray, and good correlation with disease activity. So one of the ways that we start getting pulmonary hypertension is because we have lung disease. And if you think about the lung, it has about 50,000 small blood vessels in the lung. And now we're going to start adding any of our interstitial lung diseases into the mix here. They call scar, and part of that scar are our alveolar spaces, your forced vital capacity falls. But the other piece of this are the blood vessels inside the lung. And what's been shown in animal models is it takes about knocking out 1/2 of your blood vessels in your lungs before the first millimeter of pulmonary vascular pressure or pulmonary artery pressure rises. And so think about that. We have 50,000 blood vessels. When you and I are sitting here breathing, we have a lot of the pulmonary vasculature that isn't even being served by blood right now. It all goes with gravity to the bottom parts of our lungs. And as we start knocking off individual blood vessels one at a time, we start moving our pulmonary vascular supply higher and higher in the lung, but the pressure does not elevate until 1/2 of your blood vessels are gone with any sort of vascular disease. So when we are getting ready to do a lung transplant for idiopathic pulmonary fibrosis here, we have about 1/2 of patients that have pulmonary hypertension. That means they've scarred more than 1/2 of their vasculature in this process. And so do I think that I can put a vasodilator into the mix and salvage these people's pulmonary vascular pressures or improve their outcome? And the answer has been we've tried really hard with lots of studies, but the answer is no. We cannot fix the pulmonary hypertension of obstructive lung diseases like emphysema or of the interstitial lung diseases like IPF with pulmonary vasodilator therapy to improve the outcome of a patient. And many of you may be aware the Institute of Medicine came out with these Choosing Wisely campaigns about 3 years ago. They challenged all of our professional societies at the subspecialty level to pick 5 things that we do wrong, that if we quit doing them, we would also save money in America and improve the health of our patients. And of all the 5 out there, it was to quit prescribing pulmonary arterial hypertension medications for pulmonary hypertension that's due to lung disease or pulmonary venous hypertension from heart failure. And if you think about it, this really rare disease, PAH, generates a whole lot of buzz. And what happens is people think, oh my God, this guy is so short of breath, can't I help him in some way? And then the echo comes back with a pulmonary artery pressure of 70, and boy, we want to fix him if we can. We've got all these medicines out there, but they don't work for pulmonary venous hypertension, that's congestive heart failure, and they don't work for our interstitial lung diseases and other lung diseases that cause the limitation of vasculature that makes that right heart work really, really hard and send pressure elevation inside the lung. So that's pulmonary hypertension and IPF. It's one of the disease states that we see most often with pulmonary hypertension. And let's talk a little bit about our pulmonary circulation. You know, it's a really low pressure circulation, and we've already talked about how many extra blood vessels we have in there. One other great thing your lung blood vessels do is a great filter. So it catches all those little pulmonary emboli that you have during your hip replacements and other things, and does so pretty effectively and keeps them from the left heart circulation and having strokes and renal infarcts. And when we start looking at the actual numbers here, remember that our pulmonary artery pressure on average is somewhere between 15/4 and 30/12. These are the low end and the high end of our normal pulmonary circulation. So we're talking about on the blood vessel side on your arm, that's 140/70, but in the lung, these are really low pressure circulations. What I tell my patients when they come in is that we would love to be able to put a blood pressure cuff around that main pulmonary artery inside their lungs, and that's what we're really talking about when we're talking about pulmonary hypertension. But I think most of us don't recognize how low these pressures really are. And the average, when we talk to our pulmonary arterial hypertension patients, diagnostic delay between their first shortness of breath on exertion to actually coming to medical attention is somewhere about 7 years. And so this delay and the whole diagnostic dilemma of why these patients take so long is because this is a really rare disease, and we start looking at all this process that happens in between. The next step, PA pressures elevate just with exercise. Can we get a blood pressure cuff around you or an echo while you're exercising? Yeah, but boy, our cardiologists that do exercise echoes have a really hard time getting an adequate envelope to be able to assess these pressures. It can be done in research centers. We start getting then persistent PA pressure elevation. So remember, you're starting with a 15/4 blood pressure in your pulmonary arteries, and now how high does it take before your echo picks up pulmonary arterial hypertension? We think that number is about 45 millimeters of mercury on an echo RV systolic pressure before our heart cath that tends to have lower pressures is actually going to be positive. And then we start getting RV dilation and hypertrophy, and then dizziness, syncope, and death are the way that too many of our patients come in. So somewhere in this timeline, we want to start thinking about can we do a little bit better job on how to recognize pulmonary hypertension. So let's turn to our first case now. So RG is a 48-year-old woman who is diagnosed already with idiopathic pulmonary arterial hypertension at a major medical center 24 months ago. Her right heart cath had a pulmonary arterial pressure, remember it should be 30/12, of 110/54 at the time of her treatment initiation. She was placed on sildenafil, one of our medicines that works, ambrisentan, another that works, and a diuretic, and she felt better. She's been getting more edema. She gained 10 pounds and is now more dyspneic than when she was diagnosed. A repeat echocardiogram shows that now her right ventricular pressure is estimated at 76 millimeters of mercury. You should advise her A, B, C, D. Now, A is the current dyspnea is likely due to a medication side effect since her PA pressure is lower. B, she should increase her diuretics since it will likely solve the problem with her shortness of breath. C, she should immediately call her pulmonary hypertension nurse at the major medical center where she was previously seen and get an appointment as soon as possible. Or D, she'd enroll in hospice since she is on good drugs and there's not much more that she can do. Please answer now. Yeah, I like that one too. 100%. Okay, we're reaching out. Good. I think my right answer is pretty much the same, is that these get really complicated, and most of our major medical centers that have pulmonary hypertension programs do have a nurse, and this program wouldn't work with all the medication pre-certification programs without having a pulmonary hypertension nurse that these people are on kind of one-to-one first-name basis with when they have truly diagnosed PAH. And so I think this is the right answer. What we're going to do when we see her, though, is that we are going to get that extra 10 kgs of fluid off. of her with diuretics. So if you wanted to start diuretics, I wouldn't have any problem with that. There are people that these medicines actually make worse instead of better, so we are always tracking their outcomes as we add new things. And we recognize that what has happened over the past 20 years in pulmonary arterial hypertension care has been a prolongation of survival. And so, she's not on our best medicines for pulmonary arterial hypertension, which are our prostacyclin infusion medications. So we've got a lot more that we can do for her, and this is 10 more years if we get her treated well. So I'm not ready to go on to hospice yet in this individual. So I think you should get her back to the major medical center because she really is on good therapy. And if you're failing this, and one of the reasons that I presented her with now her pulmonary arterial pressure coming down from 110 to 76 is that this is a real important slide in this whole group of diseases. And think about these diseases as diseases of our pulmonary blood vessels. And what happens is our pulmonary vascular resistance, as it gets worse and worse, we're narrowing and occluding blood vessels, means that that is reflected in your pulmonary artery pressure only up until the point that your cardiac output can be sustained. And what happens at some level if you start getting RV dysfunction is that then your pulmonary artery pressure will fall as your cardiac output begins to tumble. And so even with therapy that is over time, our goal in the early stages is to reduce pulmonary artery pressures. But pulmonary artery pressure and what you see on echo is not as important in our long-term outcomes as your ability to maintain cardiac output. So do we really want to be doing heart caths and measuring cardiac output every 6 weeks, every 3 months, every 6 months? We really don't. And so the other correlate of cardiac output is our exercise capacity. And this is why exercise is the outcome that is licensed every one of our drugs for pulmonary arterial hypertension. We're all about what's happening with your cardiac output. The World Health Organization usurped the state of New York. They used to have the New York functional class for heart failure, and this has been now called the WHO Functional Assessment for PAH, Pulmonary Arterial Hypertension. Class 1 are symptoms don't limit your physical activity. Class 4, inability to walk 10 feet. And we have different grades that are classified, and all of our drugs for this disease are classified by grade. But the test that we use minute to minute, day to day in our clinics is our ability to exercise. And what's been shown is if you put people on treadmills, they do okay with this, but a test called the 6-minute walk test is actually more accurate than a treadmill on being able to determine cardiac output correlates and quality of life and functional assessments. And that's because people kind of walk at different paces. On a 6-minute walk, you can pause if you need to. You can go out of the gate too fast. You can slow it up. You can kind of pace yourself over the course of 6 minutes. So this is a timed walk test. It's non-encouraged. You can't say, go, Ms. Jones, go, 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 up and down the hall in your office. Instead, you tell them that you really want to see how far they can walk and measure their walk distance during 6 minutes with a stopwatch, and you have to have a measured pathway inside your office. I have one of my primary care clinics that just doesn't have the office space. They're a little tiny deal. So they take them out in the parking lot, and they have a little course set up outside on pretty days. Of course, we live in Charleston, and so it works down there. And it doesn't work. I cancel appointments on rainy days. But it's a measured walk distance for your 6 minutes to go. You need to have, it is an exercise test. You need to assess both pulmonary and cardiovascular measures on this limited walk test that you can then bill for Medicare and others. But it is an oximetry. People that have COPD have to have really advanced disease before their oximetry falls. But the interstitial lung diseases and our pulmonary vascular diseases are the people that plummet their O2 saturations. So we don't like to limit oxygenation during a walk. So we'll turn up their oxygen. We'll use our 6-minute walk test to help titrate our oxygen. And at the same time, you need a heart rate and blood pressure and what happens over the course of time. In you and I, our blood pressure goes up with exercise, in some of our pulmonary hypertension patients, if you can't get blood from right heart to left heart, particularly your systolic blood pressure will actually decline with exercise. That's a bad sign. It means your right heart is not doing what it needs to be able to maintain cardiac output. And so we have to record and grade the exercise limitation, but this is not a hard test to do. Our guidelines through the American Thoracic Society say you need to have CPR capabilities, so you need to have a crash cart somewhere in your office, and a lot of people just don't have the room. The minimum of 100 feet where you'd walk back and forth in an office hall and how much congestion you have there are the standards by which we would say this is a good place to do this test. But this is the test that we do every 3 months in all of our pulmonary arterial hypertension patients to figure out if they're doing well or not on their disease. And it's amazing how many people are losing their exercise over time and need to intensify their therapy. And we do that before they reach a crisis situation. Okay, so we're going to, I know the slide is a little bit small here, but we're going to talk us through the 5 different classes of pulmonary hypertension. We've talked about pulmonary venous hypertension from heart disease, that's diastolic and systolic heart failure. We've talked about the lung diseases that cause parenchymal disease and obliterates blood vessels. But what we haven't talked about are our pulmonary arterial hypertensive diseases, and we haven't really talked about chronic thromboembolic pulmonary hypertension. There's a miscellaneous category, category 5 over here, that we're not going to talk about, but there are a lot of really rare diseases, Gaucher's disease that affects the vasculature, for instance. Leave those if you diagnose pulmonary hypertension, you can't figure it out for your specialist, but I think everybody needs to recognize that we need to do a little bit of pulmonary embolism work here, and then we've got this whole group of diseases that have pulmonary arterial hypertension. PAH, pulmonary arterial hypertension, means it's the pulmonary arteries and the arterioles that are involved with disease. And so our chest x-ray findings are pretty subtle sometimes. This is a pretty advanced example of where the large proximal pulmonary artery gets to be very large. We have right ventricular hypertrophy. We can see the right heart border more prominently, even though the left looks to be pretty normal. And then we have rapid tapering and clear lung fields in the rest of the x-ray. Pulmonary emboli can present this way. We sometimes see in pulmonary emboli chest x-rays little tiny abnormalities at the periphery of the lung. The Hampton's hump and the pleural effusions, though, make up less than 10% of those. I like to classify pulmonary embolism into 4 different classes. Acute embolism with and without infarction. They have different symptomatology. We've got then the massive pulmonary embolism presentation that you need to be aware of if you work in the ER. And then we've got this whole concept of the slow but steady multiple pulmonary emboli that accumulate over time and present just with pulmonary hypertension here. This is a 1975 slide. It's the oldest slide that I've kept in my pulmonary vascular disease slide deck. Came out of San Diego and Dr. Ken Moser from way back when. But I don't think the epidemiology has really changed too much since then. And what they estimated back then was that there were 630,000 pulmonary emboli that occurred in America every year. Death within 1 hour, 11% of those. There are going to be people that die. There's none of us that can do anything about it. They die in the ambulance on the way in despite resuscitative efforts. They die at home. But what that means is that 89% survive more than an hour and meet our medical criteria. It's estimated that we make the diagnosis and therapy is initiated in about 29% of those people. And that's where our real opportunity is to recognize the diagnosis better, because if we don't recognize the diagnosis, then we get about a 30% death rate compared to if we make a diagnosis, then an 8% death rate. And so how do we make a diagnosis of pulmonary emboli is the reason that every emergency room these days with lots of oximetry depletion or any sort of dyspnea on exertion in which the cause is not obvious, boy, it's straight to the CT scanner. And the number of CT scans done in America in emergency rooms has really skyrocketed. It's the way we look for interstitial lung disease. It's the way we find lung nodules. It's part of our, it's a very significant part of a pulmonologist's referral base or the emergency room presentations looking for emboli. And yet there's really no other great way to do this screening. And we can talk about D-dimer and other things if we want to in the question-answer period. But it's really the four tenets. We're looking for risk factors here: malignancy, obesity, smoking, hypertension, oral contraceptive use, recent surgery with immobilization that are our risk factors. And then we're trying to look at then our symptoms as they come in the door. We recognize there are a fair number of pulmonary emboli that have minimal symptoms, and I think this is going to be one of our topics here this morning. They get transient dyspnea, they get a little tachycardia now and again from these events, and the question is, do we really have to treat them or not? And we'll talk about that in a second. We have moderate cases with or without infarction, and so with infarction, remember that what happens is you kill a part of the lung, and that piece of the lung, that lung segment, extends all the way out to the pleural space. So all of our pain fibers are in the subpleural and the pleural surface. So if you don't involve the pleura, you're not going to have pleurisy, and so you won't get pain. But most of these that have some pain are going to have small infarctions when you actually look at them pathologically. And that's about 10% of all pulmonary emboli. A few days later, when we start getting cough and or hemoptysis, 10% of our patients present with hemoptysis. The stitching pleural pain, mild jaundice could occur. These are signs of lung tissue necrosis. And the problem here is that this, and you can occasionally get a large enough infarction that it gets a little lung abscess and a little cavity inside of it. But this is only 10% of all pulmonary emboli of moderate size. And then we have the massive emboli. These are the ones that present with our indications for thrombolytic therapy. These are systolic blood pressures less than 90 millimeters of mercury or syncope. And these have mortality between 30 and 60%. So we're going to move on these very quickly. Our medical center just put, we had so many arguments about how best to treat these with our new catheter-directed therapies that have now been FDA approved, that we put in place a mandatory consultation between the radiologist, the cardiologist, and the pulmonary guys who have to come together within 1 hour to figure out what we're going to do with some of these massive cases. But this is whenever the clot burden exceeds our pulmonary vasculature by more than 50%. Remember, it takes 50% occlusion before your pulmonary artery pressures begin to rise. And then what we really don't know, if you don't have syncope or hypotension, or to the extent of how much RV strain is tolerated. And we now know that about 60% of pulmonary emboli actually have some RV dilation and strain, which is not by our guidelines yet an indication for thrombolytic therapy, but does add risk. And so we're now beginning to risk stratify our patients to figure out if they should be in the ICU or on the floor. We treat a very few of these mild cases with outpatient Lovenox from the emergency room, but most of the time when we recognize pulmonary emboli, that's an inpatient hospitalization in most of our institutions. We recognize sudden deaths part of this presentation. And then we get the recurrent showers of pulmonary emboli that are often asymptomatic. These are the people that show up with pulmonary hypertension, but on a CT scan, you don't see any clots in the lungs because typically they're too small. And at the same time, we have abnormalities of ventilation perfusion lung scans that make the diagnosis that this is a chronic thromboembolic pulmonary hypertension patient. When we have acute emboli, we know that about 4% of them don't resolve their clots with heparin or Coumadin therapy. Our investigations here are blood gases, looking with VQ scan and a CTPE. In rare cases, we go to pulmonary arteriography. So what we're looking for in the emergency room are going to be blood vessels that are occluded. This could just as easily on a single cut be a lung nodule, but you'd follow it down for a cut or two and actually see that this is a blood vessel. The classic presentations, you're actually seeing the clots. These have to be really thin sliced sections of your CT. And the most important part of this is actually your contrast bolus that has to go in. There are a lot of these that really are not done well across America, and so you really need a radiologist who knows what they're doing to be able to get a really good scan, to be able to get the resolution sufficient to see this, because this might be the only abnormality you see in one peripheral blood vessel in the lung, and yet that brings us to our case number 2. So, JW's 37-year-old male. He's a school bus driver. He's had pleuritic pain. This started Sunday while watching TV. He thought I'd check it out this morning, which is more than 24 hours later. His primary care noted normal vital signs, recognized that the pain had gone, but went ahead and sent him for a chest CT scan with contrast. They see a single small filling defect in the right lower lobe pulmonary artery and sends JW to the ER for evaluation. His blood pressure is normal, his heart rate's 106, his respiratory rate's 14, and the patient's afebrile, and leg venous ultrasounds show no clots. Your best course of action is A, B, C, D. A, start the patient on low molecular weight heparin and send him home for follow-up with the primary care the following day. B, admit to the hospital for intravenous heparin. C, discharge him to home on no therapy with a scheduled repeat leg ultrasound in 2 weeks. Or D, begin low molecular weight heparin and order an echocardiogram to assess the disease burden. Please answer now. Yeah, so my brave got up there, wants to send him home. Like it. Yeah, I think the right answer is D, where we begin low molecular weight heparin, which is now in our antithrombotic guidelines supplanted intravenous heparin as initiation of therapy. And at the same time, we need to look at his risk factors a little bit more. We know that this guy is probably at pretty low risk. He really has a minimal tachycardia. He obviously has symptoms that have resolved a little bit. But half of our patients at time of presentation have lost their venous thromboemboli identifiable by ultrasound. And the important point, the reason I brought this case, was that a single tiny clot does not estimate very accurately the true clot burden throughout your lung. So we use our very highly sensitive and specific test of the CT pulmonary angiogram to identify the diagnosis of pulmonary emboli, but it's not very good at all at risk stratification unless you see a large saddle embolus. So to identify even a small blood vessel that has an intraluminal filling defect, like I showed, does not really let you figure out what your disease burden is. It doesn't add and let you look at the comorbidities associated with some of these patients. The point being is that if somebody had bad COPD and had already knocked out a bunch of their blood vessels, having the addition of a pulmonary embolism has much more physiologic impact than someone that otherwise has normal vasculature inside their lungs. And so the right answer here is to do an echocardiogram to look at the degree of right heart strain that's happening to help risk stratify your patient here. And on the basis of our echocardiogram, then we'll make our triage decisions of who goes in the hospital, any degree of RV dilation, interventricular bowing, your patient goes in the hospital, because those are the individuals that are at highest risk. And the highest risk after initiation of therapy with a heparin is in that first 24 hours after identification of the disease state. So we would keep him in the hospital for 24 hours, make sure he tolerates therapy well, and go from there. I have a quick question, yes? So I didn't do it. The primary care doctor ordered the CT scan. There actually are a family practice study that was done about 10 years ago, pleuritic chest pain in the office, in which everybody got a chest CT scan. Pulmonary emboli ended up being 30% of all cases of simple pleuritic chest pain that we might just call pleurisy. And obviously, if that's preceded by a viral illness and runny nose and all the other signs and symptoms of viral illness, then I think many of us would forego a chest CT scan. But pleurisy out of the blue is a warning sign for pulmonary emboli, and we've recognized that this is a pretty common diagnosis, and it's really, really easy to miss. And so I don't think anybody's going to get a malpractice suit over not ordering the CT scan here, but it was done. And the point of the case is that it showed only a small blood vessel in one segment of the lung, but you can't dismiss that because it does imply disease. And I'm with you that not everybody would have gotten a chest CT scan here. So my best course is that we are going to be beginning low molecular weight heparins, our drug of choice in the situation of new onset diagnosis of pulmonary embolism and or DVT here. And the reason for that is when we start intravenous heparin, we often miss our therapeutic window in that first 24 hours, which is the critical time for a new and fatal pulmonary emboli to begin, which led our guidelines committees to go ahead and recommend low molecular weight therapy as preferred, or fondaparinol as your second agent. So let's spend the last bit of our time. We'll take some questions at the end here on PAH, rare disease, mean pulmonary artery pressure greater than 25 millimeters of mercury, but you have to have no pulmonary venous hypertension. It's a disease of the pulmonary arteries. We get thickened, and then we get these things called plexiform lesions. They're bundles of scar out in the periphery of the lung that limits and worsens our pulmonary vascular resistance, and our right heart just can't pump blood from the right to the left heart. We get all of this vascular remodeling and then a little clot in the middle that then obliterates our vessels. And so all of our therapies are trying to remodel our pulmonary vasculature. We have lots of different causes, and not to go into any of them, but we do have some gene mutations that are associated with this that account for about 30% of our idiopathic cases. We have liver disease, we have drugs and toxins, fen-phen being the most memorable of recent vintage, and then we have a lot of collagen vascular diseases, the most important of which is scleroderma. HIV is on this list. There's some congenital shunts, unrepaired VSDs, ASDs through the years. Our workup is long, so we've got to exclude lots of things that we've been talking about, including pulmonary emboli. The point is that when we have unexplained pulmonary hypertension, PAH is a specific disease. We have to prove it's in the pulmonary arterioles before we make the diagnosis. And so we have three pathways that help us open up the blood vessels in the lungs. The nitric oxide pathway involves particularly a cyclic GMP receptor here, so we vasodilate the two most important organs in the body. That would be the lungs and the penis. And so that is, we're using sildenafil and tadalafil here. And so those medicines we are often joking about with our PAH patients in the clinic, but they're very effective. And they're usually the first drugs that we start in PAH to affect vasodilation and to improve symptoms. The endothelin antagonists, there are now 3 of them out there that are oral pills that hit either the endothelin A or B receptor, and there is a feedback loop up into the nitric oxide synthase pathway. Our strongest drugs are the prostacyclins. They vasodilate, and yet they're very short-acting. We do have the first oral one out this year, but it still has a whole lot of vasodilation in the belly and diarrhea side effects associated with it. But these are working through a cyclic AMP pathway. Remember that in medical school we learned about prostacyclin as a vasodilator, thromboxane as a vasoconstrictor. So we're actually infusing continuous infusion prostacyclins or inhaling prostacyclins into the lungs 3 times a day to open up and vasodilate our pulmonary vasculature, and that lets the right heart send blood to the left heart and maintain cardiac output, and these patients survive. And so our pathway of therapies here used to be calcium channel blockers. There are about 5% of patients that are calcium channel blocker responsive that we still use these drugs in because they're cheap. But we've now had about 20 years of prostacyclin and then a bunch of medicines that many of you might not have heard of because these are very specific for this disease state. And in my opinion, really shouldn't be used outside this in a pulmonary hypertension of other diseases. The one exception to that is the most recent addition, Riosequat, which actually got an FDA indication for pulmonary embolism-associated pulmonary hypertension, which happens in that 4% of patients who get pulmonary emboli, chronic thromboembolic pulmonary hypertension that's inoperable. There are some people that have big clot burdens proximally, and we send those for a pulmonary thromboendarterectomy. They get a median sternotomy, and you go in their pulmonary arteries and you pull out all the clot, and you cure those individuals. But if their clot burden is too far out in the lung, they actually do respond to some of our to Riosequat at least, and likely to others. There have been some nice trials done with epoprostenol that show that you can improve outcome in chronic thromboembolic pulmonary disease. We do have guidelines for PAH. Our worst of the worst patients get an IV prostacyclin, and then we go by functional class that we talked about of our therapies. We don't treat functional class 1 patients. We watch them very carefully unless they're calcium channel blocker responsive. And so we're looking at treatment naive and rapidly progressive disease as having different, but most of the time we're going to be starting 2 drugs plus a diuretic. Your job, if you acquire one of these patients, is to really monitor their amount of edema, make sure that they can maintain their exercise, our best measure of functional outcome with their cardiac output. So in conclusion, dyspnea, begin with the basics. Y'all are in this every day, and you're the people that are going to be able to pick up some of these rare diseases. Listen to your patient. A normal test or 2 doesn't mean your patient's lying when they're saying they're short of breath. And we have lots of causes for that to happen. Dyspnea is not something you can see, and lives are saved by early diagnosis. You probably have a pulmonary hypertension program somewhere near to you. There's always, in our group of 20, there are 2 of us that do pulmonary hypertension, and so there's always one of these, not that everybody doesn't know something about it, but to have a pulmonary hypertension nurse and some people that really focus on the disease helps all these medications and move through the basics. Importantly, there's also a patient organization. The idiopathic pulmonary arterial hypertension is a female's predominant disease, and they're all about trying to help patients and have great clinical materials for your patients and recognize and recommend this to your patients with PAH. So I'll pause, and we're right on time. I've got time for about 2 minutes of questions, and I will leave more time. I had the first question here, and then I'm going over here, and then I'm going here.
Just real quickly, if you comment on the D-dimer, and particularly how it would relate to your bus driver case.
Yeah, so the D-dimer, if normal, is a very, very good test. The problem in all of our emergency rooms is about 90% of them are not normal. And so if you come in and have a D-dimer and you have a lab that's very responsive to be able to get it back to you so you don't clog up your emergency room waiting for D-dimers to return, then it's a very helpful test, but only if it's completely normal. Yeah. So last year, the first of our direct thrombin inhibitors got an FDA approval for pulmonary embolism. I think we've had a few cases, and this I hate speaking on case-by-case examples, that have been on a direct thrombin inhibitor that have been in their first week of pulmonary emboli and come back with recurrent emboli. That doesn't happen so often with our heparinoids. So I'm thinking that we have about 30 years of experience with our heparins. We have about 1 year of experience with our direct thrombin inhibitors, and they certainly serve their place. I often will do a heparin continued and or transition to Coumadin for a month, and then have this discussion about whether you really want to monitor your INRs over time a month out now that you know your patient's doing well. So that's my personal pathway. There are no comparative trials on how to use these in clinical practice. Very important and good question.
Can you offer your opinion about the role of IVC filters with recurrent pulmonary emboli?
Yeah, the question is IVC filters for recurrent pulmonary emboli. Very helpful in preventing the next clot in the acute situation if you can't anticoagulate your patients. So we do these a lot, particularly within the first 24 hours of an acute PE presentation. There have been lots of controversies through the years about whether they clog up with filters and how effective are they, and those studies continue to come out. But the autopsy series show that these are 99% clean when autopsy is performed. They do add to the burden of deep venous thrombosis subsequently over time, So we'll sometimes reevaluate and figure out if the reason for not using an anticoagulation strategy is still there a month or 6 months later, because then if you start having recurrent post-phlebitic syndrome, you didn't really help anybody if that's the major cause of your symptoms. But very effective, and I think the concerns about inadequate placement, we now have the removable variety if you have that situation where you have a short-term risk.
So you don't think they have to be retrieved, they can be left in place?
Most of our radiologists now are putting in the retrievable ones for the just-in-case scenario. So, but you'll have a lot of these through the past 30 years that are not retrievable, and I'm okay just leaving them be.
Last question.
Can you just elaborate a little bit on the question of medication, the new medications for pulmonary hypertension? I have a patient that has a cardiomyopathy. She just got started by a cardiologist on all these medicines. And can you review again when you do enroll these?
Yeah, so the question is, our Institute of Medicine said we can save money and improve the health of our patients by not using PAH medicines when the cause is either due to pulmonary venous hypertension, in your case from a cardiomyopathy, or from intrinsic lung disease that's not specific to the pulmonary arterioles. No, so pulmonary arterial hypertension, that included the HIVs and the portopulmonaries and that list that I had up there. And so we recognized in today that about half of pulmonary arterial specific medications are prescribed wrongly in America. And that was one of the reasons that in this rare disease, it made that top 5 list in pulmonary medicine. And so we are coming at this with a really hard eye about who needs these medications and not. There's been some interesting work. If you really can regress the pulmonary vasculature or smooth muscle, why wouldn't you use them in diastolic heart failure to decrease the left ventricular wall thickness? And yet all of those studies have been negative thus far. So they've been trialed in diastolic heart failure and other things. They don't make a difference in outcome.
In a practical sense, real world, have you seen cardiologists using them often when they shouldn't?
Yes.
So therefore, we should send them all to you.
Well, we should send them to a pulmonary hypertension center. So what we do every day is we take people off of medicines they don't need. So we actually take more people off of these medicines than put them on at a pulmonary hypertension center.